Good morning, everybody. We'll go ahead and call the meeting to order and go right into the approval of the minutes from the May 7th meeting. Can I get a motion on that?
I move approval.
I'll second.
First and second, all in favor?
Aye.
Opposed? Motion carries. Med staff meeting summary.
Yes, that's me today. So yes, Med staff met on May 14th. A few highlights, quality improvement, Nancy Gao and Adam Porter, two of our pharmacists, met with medical staff, gave a presentation on diabetic foot infections. Carrie Sonderman from Diagnostic Imaging joined the medical staff, discussed low-dose lung CT scan orders. Those orders were reviewed with the medical staff, basically make the process a little easier for them, and they all approved those changes. Joint Conference Committee meeting policy and procedures were approved by the medical staff. Infection Prevention Committee basically just kind of went over their minutes and noted that there have been 125 cases of measles in the United States and some of the surrounding states of Iowa, so the medical staff know about that. ER changes, so Heather Smith came and talked about documentation for the medical staff, basically what documentation they need for any critical care patients that are seen in the emergency department. There are some webinars out there as well to help the medical staff with their documentation for those types of patients. From the clinic, Kim talked about DAX, which was going live with a couple of test practitioners, and then actually today is actually going live for the rest of the medical staff. Basically that is a way to help them with some medical terminology when they're working with patients and help with their documentation as well. Kim also talked about the narcotic agreements that we have with our patients. Some of our patients, if they are using illegal substances, they are on contract with our medical practice. There is a new, I don't know what you want to call it, Delta 8, which is a legal substance in Iowa, but it will turn the drug test positive. So basically just kind of talking with the medical staff about that substance and what they want to do moving forward. A lot of discussion, but they hadn't really come to any conclusions yet with that. They're going to talk about it again at the next meeting. Also talked about transitional care management. This is management from patients going from acute care in the hospital, returning back to outpatient services through the Real Health Clinic. Talking with medical staff about how our health coaches are helping with that, and then how to code appropriately for those situations. Jill Megas gave a recruitment update, and Christy did the March financials with medical staff, and all of the medical staff at this meeting were on their phones. They now have Duo, which is basically a way for prescribing narcotics with dual sign-offs, so that it's done officially. So that was put on all of their phones so they can do that in the future. Any questions from the medical staff meeting?
All right, no questions. We'll go to the Personnel Committee report by Janine.
Personnel Committee met this morning for credentialing. We had 4 initial appointments, 10 reappointments, and 7 voluntary withdrawals. I would make a motion to accept these as presented.
We have a motion, we have a second.
I'll make that motion. Or second. Whatever you want me to do.
We got a second. All in favor?
Aye.
Opposed? Motion carries. Next we'll go to Perry, consideration for the approval of expanded architectural design.
Did we miss something?
Yeah, do you mind if I do the joint conference policies? Sorry.
We were going to defer that.
Yeah.
She's here now.
Now I'm here.
Oh, okay. I
Is
thought
that
you
all right?
mentioned a little something about it, but no, sorry about that. Let's go
Well,
back.
yeah, we did it with medical staff, but now I have to do it with you guys. So.
Oh, okay.
So joint conference policy and procedures, I'll pass those around. Sorry, I could have just kept going. I'll go over these pretty quickly. It's in your packet, starts on page 7. But for the first part of the meeting, for the joint conference, we go through full policy and procedure manuals for the full year. So this time we went through cardiac rehab, diagnostic imaging. With diagnostic imaging, the biggest thing with that is for patients who are having IV contrast, they have to have some lab work done, so just a lot of policies related to that. Emergency department, environmental services, information services, occupational health. With occupational health, they are now doing in-house audiograms, hearing testing. as well as they do DOT physicals both for OHO patients as well as non-OHO patients. So those are their changes. Outpatient specialty, patient access, basically a few new policies for them. EMTALA for ER registration, registration checkout, so basically when a patient's been seen that they check out through registration. Returned mail policy, so those are some of their new ones. Perioperative department. Public health, basically there's a long section on public health. The main thing with that is there is a merger for within the state for the Department of Health and Human Services and the Iowa Department of Public Health. So they merged together into one, so a lot of their policy changed just by pulling those two together into that merger. So that's like the next 3 pages. So those were all of the full policy and procedure manuals that we went through. And then for just the quarterly policy and procedure manual, so this is just any new changes from the last quarter. With administration, there's a new standard of practice for facility-wide for 2 patient identification. We've always been doing this, but different places had different practices. So now we're doing the exact same practice throughout the facility. So 2 patient identification there. With dietary, again, a long section, but basically what this is showing is an update. The critical access hospital regulations changed their numbering system. So we a lot of times would put those regulations straight into our policies, but because they changed all those numbers, we had to change all the numbers in the new policies. So even though it looks like there's a lot of changes, it was just a changing of the numbering system there. So that's another whole couple pages there. Human resources, their newest one was internal communications. We had a committee on in communication throughout the facility. The committee just talked about what they'd like to see with internal communication in the facility. So we had some guidelines that were formulated by that subcommittee and put that into a policy. So that was their big one. Infection prevention, again, those were all those critical access hospital tag numbers changed. So another big section there, but it was all number changes. Medical records, access, right to access policy, consent for disclosure policy, so a lot of making sure that medical records are disclosed or have access to according to policy. Nursing administration, again, a lot of those CAW tag number changes. Senior Life Solutions, they have a new electronic health record, so they had a few policy changes for that electronic health record. So that's kind of in a nutshell. Otherwise, all of the full policy and procedures are in that manual. Unless there's any questions, we do need that to be approved by the board.
I have one question. I'm kind of new on this board. Under occupational health, you have OHO and non-OHO patients. What does that mean? I mean, I can figure occupational health, but what's the last O?
Occupational health outreach.
Outreach.
Yes. So basically, they have their clients that they have, but we were also doing it kind of through the clinic. Any other people who needed a Department of Transportation, a DOT physical. And so we've actually now just put it all into one system so that all patients are treated the same way in essence.
Okay.
Make it simplified, basically for patients, so it's not 2 different ways of doing something.
Thanks.
Okay, for all the questions, can I get a motion for the approval of Joint Conference Committee policy and procedure revisions?
I will move the approval.
I'll second it.
First and a second, all in favor?
Aye.
Opposed? Motion carries. Janine already did the personnel committee. We'll go down to Barry and the approval of the expanded architectural design.
Okay, so I'm going to provide you a lot of information that you've probably already seen, but I think it's important to make sure we're all on the same page with why we're considering what we're considering here today. I'd like to start out with a little bit of the history. So going back, way back to 2020, the board had approved an east addition to the rural health clinic with a second floor addition for behavioral health. I'm not going to be able to see this very well, but moving on to May of 2020, we delayed the project because of the pandemic. Also, during about that time frame, we moved behavioral health down to a larger building, so they got quite a bit more space. Spring, summer of 2023, we started to talk about this expansion again. I think it goes, maybe started back in a meeting we had in March of '23, was where we had a lot of discussion about what was needed from a facility standpoint. Then in November of '23, we hired Murray and Altus to do a master facility plan focused on rural health clinic, med-surg, specialty clinic, and surgery. And the majority of that was to be focused, heavy focus on rural health clinic. January, February 2024, the master facility plan engagement was complete. We brought to you a recommendation, I think it was February 6th, to get approval to contract with an architect for that one floor addition to the rural health clinic. One other thing that I think is key that I didn't put on here was in March we learned about changes with reimbursement for our mental health counselors and licensed independent social workers, which would make them eligible providers in a rural health clinic and increasing our reimbursement for both the rural health clinic and behavioral health significantly. I think that's a pretty key, for this whole discussion today, that is a very key item for us to consider as we're moving forward here. I wanted to go back on just what some of the goals were of the various areas of the project. So rural health clinic goals, obviously we wanted additional exam rooms and additional provider offices, better patient privacy, centralized storage and supplies, improved patient wayfinding, more efficient use of the space, and more efficient use of staff. So those were some of the high-level goals on the rural health clinic. This is something I presented before, some of our growth within the rural health clinic, providers that we have added over the last probably 4 years. And then, of course, Brelgy and Dr. Hylison both have transitioned to ER 100%. So that's, I guess, important to keep in mind as well. But right now in the rural health clinic in Harlan, we have 14 providers that are working out of that rural health clinic, and we have one, and we're also recruiting for another provider. And then we've got the providers that work out of the satellites, specialty clinic with Dr. Anderson, our general surgeon, are currently working out of the specialty clinic. We do want to move them over to the rural health clinic. There's some financial advantages, as well as we think operationally that will work well. So right now in our rural health clinic, we have space for we have 6 pods basically. One of the problems with the way we're set up right now is if a provider is gone, his exam rooms are not used, and the office can't be used as well. Moving to the new design, there won't be any dedicated exam rooms for providers, so those exam rooms can be used by any provider. It doesn't matter who's gone or who's in the ER, who's doing nursing home rounds. And that's where we get to the improved use of space and improved use of staff as well. So right now we have 12 of those pods. We will lose one through the expansion. We'll go to 5 on the first floor. We'll continue to have 6 on the second floor. And then we'll have up to 12 in the new expansion. I think that would be more comfortable with 9 or 10, but I think we're capable of having up to 12 providers in that new space. So we go from 12 to 23. A lot of this is relieving some of the growth in the specialty clinic as well. So part of this expansion is helping to relieve some of that stress in the specialty clinic by moving some of those providers over to the rural health clinic. I think that's the main points I wanted to make on this. I presented this to you 2 weeks ago. This is what has been, I think we're in the detailed design phase of this rural health clinic expansion. So this is just the first floor. And the green, this lighter green or medium colored green is the expansion. This dark green is part of the existing rural health clinic that will have to be remodeled in order to add on to this space to the east. The red is areas that we're considering renovating that are part of the existing first floor of the clinic. I think we're going to do that as a bid alternate. And then if you have any questions as I go, let me know, but this is kind of repetitive, I know, from a couple weeks ago. So moving to the specialty clinic, some of the goals, specialty clinic and surgery, an additional shared procedure room, 2 to 3 additional exam rooms, increased size of nurses station, surgery storage, standing desk, increased break room size, improved workflow of registration. So we've had quite a bit of growth in the specialty clinic. We went from about 11,675 to almost 16,000 from 20 to 23, a 37% increase over that 4-year period. I'm not going to go through all this, but this is a list of some of the new providers over the last few years. Kind of explaining where a lot of that growth has come from. These are a couple providers, some of the providers that have left over that same period of time. And we do have some potential specialty clinic growth for 2024. Dr. Veit, we have signed a contract with him, so he'll be starting in June to provide some additional pulmonology coverage. Miller's recruiting for Dr. Rickardt's replacement as well as Dr. Bodendorfer's replacement. So that's where the growth on the specialty clinic has come from. Basically, to get those additional 3 exam rooms, we're taking the cardiac rehab space and converting that into, there will be 3 exam rooms, kind of a little nurse's station and dictation area, and likely we will have our orthopedic surgeons work out of that area. Doing a little bit of work with the reception desk as well as that work area back behind it, expanding this break room a little bit. A few changes in that nurse's station, but we ended up not expanding the size of that, but rearranging the desk a little bit. The plan right now, Dr. Anderson and Dr. Hodges' offices are right here. I mean, the plan would be to move them over to the rural health clinic, opening up a little bit more space for the specialty clinic. So then inpatient goals, patient rooms, make sure that they all have showers. We want to right size the ICU rooms, accommodate bed transfer into rooms, additional storage space, some new finishes, and expand the nurse's station to improve visibility to the patient rooms. And again, this is what we showed you 2 weeks ago. These are the rooms. I mean, really we're focusing on the rooms that are very close to the nurse's station. And we are taking this supply area and moving it up here so that we can make all of this nurse's station and improve the line of sight to these rooms over here as well as the ICU rooms right across the hallway. Move on. We talked about this last year. I mentioned that kind of on my timeline. We learned, I believe it was in March, that the licensed mental health counselors are now eligible providers to work out of a rural health clinic, and we can get cost-based reimbursement for them. The additional reimbursement is somewhere between $900,000 and $950,000, and that's That's for a combined rural health clinic, combined behavioral health. It's not all behavioral health related, but a significant portion of that is helping the reimbursement for behavioral health, but it's a combination. It's helping the rural health clinic reimbursement as well. And right now, our behavioral health we do subsidize behavioral health right now. It does operate at a loss right now, so we can put them in a lot better position and sustain their financial future a lot better with, if we're able to get rural health clinic combined in with our, behavioral health combined in with our rural health clinic. So we had the 4 different options at our previous meeting, and I'll show a summary of that here in a second. But the 4th option was doing the first floor as we had planned, but then adding a second floor with about 7,500 square feet for, I think that says 7,270. We'll keep trying to get to 7,500 square feet, but so approximately 7,500 square feet for behavioral health, and then a shelled-in space in the middle of that, which would then allow us to grow behavioral health to the west, or grow our specialty clinic or primary care from this area out to the east. So the 4 different options that I had provided at our previous meeting was, the first option is just to do what we were planning to do, a first floor addition to the east for the rural health clinic, and expand that way. Option 2 was, I guess the downside of doing that is it doesn't take advantage of the behavioral health additional reimbursement. The second option was to take the existing second floor, convert it into behavioral health. That does take advantage of that additional reimbursement, but it limits our ability to move specialists over from the specialty clinic over into the rural health clinic. And it just kind of limits our ability to grow in a lot of different ways if we do that. I think they can get about 6,400 square feet out of that area, which is, we'd like it to be a little bit more than that. We'd like to get another 1,000 square feet. If we're going to go through the work and the cost of renovating, we'd like to get more square footage than this. So I guess that's probably another downside to that option. Option 3 is, again, that is building a second floor, but not a complete second floor, just enough for behavioral health, about 7,500 square feet. And then if you move to the 4th option, that's where we shell in the rest of that second floor. And I've got some costs listed down below on that, on each of those options. So just thinking about, from a really high level, I think the first decision, the board has already approved a contract with the architect to build a first floor. Now, there will be final approval that will come at a later date, but the board did commit to a contract with the architect, which is approximately $900,000 for that first floor addition. In light of the information that we have regarding behavioral health, I think the first question that we need to answer is, does it make sense to locate behavioral health in the rural health clinic on the second floor of an east expansion? We're going to have a slide here in a second that Christy will go over regarding the financial impact, but I think, in my opinion, I don't think we can afford to leave $900,000 on the table, and that slide will kind of show that as well. So if the answer to that is yes, to that first question is yes, then the question is, does it make sense to shell in the remainder of the space? So this gets to be a little bit of a domino effect. The upside of shelling it in is we can do it less expensive right now. Plus, if down the road, if we did expand into that area, it would be much less disruptive for the first floor, which will house all of our providers, primary care, family practice providers, and that's where they will be operating out of. So that's, I mean, just at a high level, I feel like that's the decision process that we have to go through. So then I listed some reasons to pursue option 4. Allows growth for new services in rural health clinic, behavioral health, and specialty services. Allows for better integration with behavioral health and primary care. Patient retention and attraction of new patients. Retention and attraction of providers and staff in a highly competitive healthcare environment. Financial sustainability is a big part of why we're looking at option 3 or 4. Shelling out remainder of second floor now reduces disruption of services in future. Shell out remainder of second floor now is less costly if done as part of this project. We did have a couple meetings with Dwayne and Roger Beeson with the city, and they did approve a parking plan that would allow us to have a full second floor added on to that, a full 2-floor addition. So the city has approved that parking plan. This is just kind of elevations that Dwayne provided us. This would be the full shell out. This would be if we only did the behavioral health on that second floor. And then you have north, let's see, that's the east elevation, and then the north elevation down at the bottom. So this is a slide that I'm going to have Christy talk about, but just a few comments about this before we turn it over. So comparing option 1 to option 3, we're really trying to isolate the decision about whether to bring behavioral health over into the rural health clinic. That's the purpose of this. And so the reason I'm saying option 1 versus option 3 is because we're trying to not consider the shell part of it. This is just referring to the decision to bring rural health, behavioral health over into the rural health clinic and the financial impact that it would have. So, you know, we're all here because we want our quality of care to be great. We want our patient access to be great. We want our service to be great. You wouldn't be here if that wasn't what you wanted. But if you were totally focused on the money and the cost of doing this, I mean, if that's all you cared about, which I know that's not the case, but if that's all you cared about, this is an important slide to look at. Because it doesn't just take into consideration the initial outlay, it takes into consideration how this affects us over the next 5 years, and you can see how it's trending. So years 6, 7, 8. But I'll let Christy talk about that now and how she came up with these numbers.
So what we took a look at was, in option 1, really provided for some of those specialty doctors to come over, but not behavioral health. And that does increase your reimbursement a little bit. Option 3 allows for both of those things to come over and increase reimbursement a little bit. So what this does is brings that reimbursement in, but we're going to have depreciation on the building. So that reduces our net gain, technically, from a bottom line net income financial purpose. And then also this is in consideration here of the interest that would be paid on the debt. So as you can see, even with the depreciation that will be partially reimbursed for the number of Medicare and Medicaid patients we have, and the additional revenue we would have, and less the interest, we're still going to have a positive impact on our bottom line. So it's not going to make us look financially it's going to make us look financially better. So it'll increase our, our auditors always go through every year, what's our financial position, where we are. That takes into consideration what some of these benchmarking entities look at us to make sure that we have good financial standing. So the plan we put together retains, and I think this is in another slide, it retains our cash on hand that is a benchmark for us. This retains our financial, our equity in the facilities, and it also retains our positive net income from just this program. Does that make sense to you? And the reason that goes down, of course, is because the interest will continue to go down each year on the loan. As you recall, I believe we were at a minimal debt for option 1, and option 3 was 8, a little over 8 million for debt there.
And that debt would be retired when?
I've got it calculated right now, it's 10 years.
Okay.
Historically, in the past project, that was paid off earlier than the 10 years.
Sure.
Is there
Questions?
anything else on that? So the recommendation that we're coming to is the option 4 with 2-story east expansion, first floor being for the rural health clinic, 14,000 square feet, second floor behavioral health, 7,500 square feet, and a shelled-in space for future growth. I would say that the option 3 is a really, really strong recommendation, and adding on a shell space I would recommend that as well, but it's not quite as strong a recommendation as getting behavioral health over into the rural health clinic is very important for us. You know, I did ask Lindsay to come. Lindsay oversees the behavioral health department, and so I thought it would be nice to have her talk about, you know, the facilities and kind of what her thinking is related to the possibility of moving back over onto the hospital, main hospital campus. So if you wanted to make a few comments.
Yeah, when we moved to our current location, we were completely out of space in our previous location. And so this has been a nice expansion to our space. It's beautiful. The patient flow is significantly better than what it was in our previous space as well. And so it's served us very well in the time that we've been there, and we've outgrown it again. And so it's been a little over 6 months ago. We added 2 more offices to our space to accommodate our growth, and we're still office sharing even with those 2 additional office spaces. We currently don't have space to be able to expand any further. We've kind of exhausted the space that is available to be able to add office space into. And we also are limiting some of the services that we can provide because of that. So there definitely has been some discussion of adding additional services, but to be able to do that, we would need to be able to have more patient space available to look at adding additional services. Our APPs have talked about a couple of different services that they would like to expand into offering, and we've had to decline that at this time because we don't have the space. We also have learned quite a lot since we've moved to that building around patient flow things. With the increased volume of patients coming into our building, our current setup of having kind of our office staff in 2 separate areas makes the flow in and out tricky with our expanded hours. So all 5 of them don't work the same days, and so not having them be able to step in and out of each other's space in a more easily manageable way has been tricky for us as well. And then over the last couple of years, we also have expanded our group services quite a lot, and we have a pretty small group space for some of the services that we're doing. And so with the addition of those services and adding more of them, we're having to schedule out group services to make sure that we're able to have the space available, and we're limiting group size for some of those to be able to make sure that we have enough room for patients to be in this space as well. So really, I mean, we would love to be back on campus. That has been our goal for a long time, of being able to be truly integrated into the hospital, and being part of the rural health clinic would allow more collaboration and teamwork between the rural health clinic staff and our staff, which we think there's quite a bit of benefit to We also feel like there's some benefit just in the reducing stigma of going to the same place for your mental health care as you go for your regular care. So we would love that as well, and we would like to continue to expand and have space to grow our services.
What's the square footage difference between where they're at now and
Say that again.
the square footage difference? What she has now and what we,
They have 5,700 square feet right now.
and
So this, right now they have 5,700, this would go to 7,500.
okay.
And, you know, that building was already built, and we were limited on what we could do with that building in some ways.
Okay.
This is pretty much a blank slate for us to design it the way we want to design it, which I feel like that should allow us to have it be a better, more efficient use of the space that 7,500 square feet, we would have better.
Our
Better
current
use of
flow
that space.
in our building has a lot of wide open space that isn't usable clinical
Oh,
space,
okay.
that doesn't allow us to expand
Okay.
into it. But with being able to start from scratch, that allows us to more efficiently plan for those open spaces.
Well, it doesn't sound like you'd ever be able to answer how much space you need from the growth. So,
Yeah, I wouldn't have predicted honestly that we would have outgrown it as quickly as we did. I feel like one of the things that have come with the pandemic is not only a growth in mental health need, but a growth in willingness to seek help for mental health need.
Sure.
And more openness around that has allowed to increase volume. I mean, our referral base continues to grow month to month. So yeah, I wouldn't have predicted we grew out of this space as quickly as we have, and it's an excellent problem to have that people are seeking care as quickly as they are.
Thanks, Lindsay.
There's just a couple more slides here, and they're financial slides. So I'll let Christy do these last couple.
So if we go with option 4, it's an estimated debt of $9.6 million is what we would borrow. The project cost, of course, will be funded from our cash reserves and the debt. The debt will be paid back from future revenues, so basically trying to say there's not any tax implications with this at all for our community members. Like I said, it's recommended for critical access hospitals to have 60 days of cash on hand, and basically we take our expenses and divide it by 365 days times 60, so that is $8.5 million for us. So the plan and the debt is built so that we could retain that cash reserve. So we still feel like we're meeting our benchmarks for critical access hospitals. This is one of the slides, a rendition of it, a slide that the auditor prepares every year that compares our debt to our capital, basically to our debt to equity ratio, but is what this is. So as you can see, we have very little. The 1.7% debt to equity has to do with the new GASB requirement. Really doesn't have debt. It's just a booking accounting standard that we have to recognize. And as you can see, we are considerably lower than our Iowa peers or Iowa critical access hospitals. There you can see they're well over 50%. Even with the 9.6 million in debt that we would incur with this project, we would still be at a 15% our debt to equity ratio, which is still well below what other critical access hospitals for hospitals of our size in the state of Iowa have.
So we'll answer any questions that you might have. What we're getting at here is the board approved in February a contract with the architect to design the first floor, and that was a cost of between $840,000 and $940,000 in architect fees. What we would be asking for today would be to increase that by $450,000 for the design of the rest of the second floor. That's what approval we are looking for today.
So Barry,
any question?
you're looking for approval of option 3 or 4 with these?
That would be option 4. I don't know that there's a lot of design, I guess there would be some design related to the shelled-in space, but
That shelved-in space would be something we could use as options for the next decade. I mean, it's not going to be customized at this point to do any specific specialty thing. It's
No,
space that we can
no.
do.
Right. And you know, this is, outpatient really is the future of the hospital. I mean, right now, we're probably 85% outpatient, 15% inpatient, and you've seen over the years what our census is doing. We are proposing to spend some money on inpatient, but it's pretty limited, and really focusing on some rooms right around that nurse's station. But outpatient is really where it is. So, you know, we're spending money on the emergency room, which we're always going to have an emergency room. We're spending money on rural health clinic, which we are always going to have rural health clinic, and specialty coverage is the other area. And now we're looking at behavioral health, because behavioral health has been a huge need in our community. We, as an organization, have decided to really put a lot of resources into behavioral health. It's at the top or near the top of our community health needs assessment every year. So it's, you know, putting us in a really good position for the future, I feel, if we go ahead and do that shelled space. And I don't know, Major, Dwayne, I mean, the cost, maybe you could speak a little bit about why it makes sense from your standpoint, you know, both as a builder, as an architect, to do that shelled space now, as opposed to some point in the future having to grow into that area.
Yeah, there's a couple of things I'd like to mention, Barry. One is the structural design. So under option 1, we were intending and are moving towards designing the footings and the steel to do a future second. Okay, so that was kind of in that option 1 plan to already do that. The other thing I'll mention is the amount of, I guess, site preparation as far as utilities, grades. That doesn't necessarily change significantly with the addition of this option 4 or the second floor. When you look at doing option 3 versus option 4, there isn't relatively much significance as far as difference. You're basically adding another floor slab. You essentially have your walls to the east, to the north, and you're pushing the one to the south, so you're adding a floor slab. We were already intending to design that to receive a second floor anyway. So we have the composite slab to receive that second floor. I think that the difference was when we were initially doing the first floor, we had the clear stories. So that has been pulled out of there with the thinking that there would be at some point a second floor. I think as this behavioral component came online several weeks ago, we started assessing this a little bit deeper. We did have an initial preliminary program to understand the needs of the behavioral department and what their wants and needs were, and just to understand, will it fit in this space? So that's something that we have already done. And then as far as just design schedule, we were initially on track to release construction documents in August, I think the first part of August. I think this will push it probably a week or two to mid-August, but still allow you to do what you need to do for Murray to start the foundations after this site preparation and utility work is done, which we're targeting and we think that we can do in mid-June. to release that package for you to start that work then. So as far as design schedule, we don't see a real impact for you to still begin work and get work done before the pool.
That's right.
I don't know if you have anything else to add, or if you've got any questions just on kind of my comments.
Do you mind, whoever's driving, pulling the slide up above the second floor? I'm a pictures guy. So and I know the shell space, I don't want to make light of the financial investment. I know it's a big deal, it's an important decision. But simply put, this wall is an exterior wall. So by making this shell space, you erect it here. So it's no cost. Whereas if you come in and fill this in later, you pay for this wall again right here. So you're long-term, you're saving the cost of the erection of this wall. And then we're able to utilize this existing wall by doing the shell space. Yes, there's some work, but this wall is more expensive rather than abutting to your existing building. So initially, yes, there's more cost up front because you're getting more finished square footage, but there is some efficiency of these exterior walls. What you're seeing in the delta to build the space is really the mechanical systems that support the space long-term. So the HVAC, the electrical, we still have to prepare this space to have life safety, lighting, temperature controls. That's why it's really efficient to do right now, because when we come back, we've got to redo our, people, just for a site work guy, mobilization's around $30,000. That's just to have them show up. That's getting everything brought over, all the trucking, all the people, all the equipment. So we'd have multiple mobilizations to come back. We'd have to do site prep around the site. While you're actively operating a rural health clinic, you're kind of tight on space. We'd be taking parking, probably ruining some parking. So that's a cost to the project. Then we're setting up cranes. It's easily done. We do it all the time. But in this option, we do that right now. So you're able to gain the efficiency. You're not paying for double mobilization. You're not paying for double site prep. It is more cost up front, but ultimately long-term, it's much more cost-effective to do it now. If that makes sense.
You spoke a couple weeks ago about the site work that needs to be done on the addition, and there could be some problems there. What happens if there are problems? So how far does that push it back? Does it move it into next year? Does that increase the cost of this thing? That's my concern, I guess.
Great question. So we've looked at 3 different options. So initially, do you mind going to the elevation? Again, does it help if I use pictures? It helps me.
Whatever, yeah.
Correction.
Yeah. Sorry, I'm putting Jeff on the spot.
No, it's Christie.
I was hoping to put Jeff on the spot.
I like option 4. I think it looks aesthetically better. I mean, I do like 4, and I think it makes sense to build it. I'm more worried about this site work that you talk about that's got some issues.
Rightfully so. So here's what our job is, to tell you what we know. Is like Barry and I have already had this conversation. This is not something we sit on. We're working. Dwayne and I had numerous conversations. So our site is kind of sloped, right? So initially, I'm just going to pretend we're only looking at this elevation. What they're telling us right now, the geotechnical engineers, we have to dig down 15 feet and take out all of the dirt. And we're able to use about 80% of that dirt. We have to put it back and compact it and moisture treat it, and then that's considered good fill. That's about $900,000. And that's tough enough to bite off. That didn't sit. We know that works. We've done it before. Yes, that works, but that feels like worst case scenario. So what we're looking at is an alternative solution called geopiers. It's something Ken and I have done numerous times. Dwayne, I'm sure you've done it a ton of times. And it's not real fancy. It's we drill a hole, we take gravel, and we pound it down. By doing that, one, we're creating it's a vibratory stone column, so we're creating a column of rock. But the beauty of it is it compresses all the dirt around it too. So we've already had 3 proposals from 3 different companies. Way cheaper to do this. We're still working on the cascading effects. How does it affect structural? How does it affect civil? But it's significantly cheaper. It's much quicker from timeline. Much quicker. At least 6 weeks quicker to do this. and we're able to shore up the site by doing that. So that's what we're still working through, but right now, all things are, I think we can remediate our soil within our original budget, meaning all the numbers we're showing you right now, we have enough money in the budget to cover utilizing geopiers. We just need to kind of cross the T's, dot the I's, make sure we considered everything.
And that's a 900,000 that you're estimating?
We had 514,000 in our original budget for soil remediation. That geopier fix fits within that 514.
And if you can't go that rate, then it's another 900 on top of that?
It'd be an additional 400 on top of that.
Okay.
Now, I do want to be fully transparent. There is rubble detected under boring number B5. That is the southeast corner of the building. No one in there, we can't x-ray the dirt, so there's no way of knowing what we're going to find there. That is your risk. I want to make you aware of that risk. Right now, we're anticipating roughly 3,000 cubic yards to be removed and replaced. That's still currently sitting within the budget, but then again, that fits within. So I don't want to dangle the carrot of saying there may be savings, but we are trying to protect your interest in saying, we're going to look at this worst case scenario. We want to cover what we think. We're still developing that with the geotechnical engineer and Dwayne and his team. There's a lot of data that we're trying to pull out in a lot of different parties, but that's the approach that we're going with right now, is we're trying to look at a worst case scenario, knowing that if we don't spend money, great, we give it back to you, you guys can reinvest in the project, do whatever you want. But I don't have enough information right now, but until we open up that dirt, we won't know the full extent, but we think we've got it covered within the budget. And that's a big deal for me to come out and tell you that, because we're stating our reputation and our assumption. So that's why we're trying to be very transparent with it, and we want to make sure we're all aligned with, here's what we think it's going to be, we all agree on the amount we're going to carry. Is that fair?
And that's in the high-end budget, number 14?
That's in our current, what we're carrying right now is in that. The only thing that's not in our current budget, to make you aware of, is stormwater detention. Is a price tag of, it might increase the budget by $200,000, but I'm going to leverage our friend Barry here to go talk to the city. They might be willing to work with on that. But it's not an uncommon thing, and it's not something we necessarily can't work through. It's just we need some more information.
Christie, on the additional debt, what are we talking about as far as payback is concerned? The time frame.
Well, I still have it budgeted in here for 10 years.
10 years.
But
It's fast. Yeah.
Are you thinking you'd bond it down, or would you just do?
we'll still have to look deeper into that. We've met with the bank, and originally when we were talking about $500,000 or $5 million, it was probably not worth doing tax funding on it, tax rebate. Basically what that means is people who don't give the money get a tax break. But now that it's grown, we'll look at that option again, and maybe even look at USDA. I know that brings some further requirements, but I'm going to look at it and see what that might mean.
And Mary, I told you I was going to ask the why, but I think you did a really good job of explaining why, and I appreciate that. I know it's been a lot of review for everybody, but I think it's important when we're making decisions like this that it's really clear to the public why we're trying to move forward, and that the cost is justified. So I appreciate that. Yes.
I just can't thank Christie enough. Getting the information when the behavioral health reimbursement changed, to know that, and then Barry, you're processing that and working through it. And to Mike, I think this was the questions that I had with the Building and Grounds Committee a couple weeks ago. This goes farther, this is significant, this is a better option, I think, for us to look at for the long term, which we didn't have quite there a couple months ago.
That's right.
Even though we had lots of information and all this backgrounding and engineering work was already in process, this does get to the why, to your point, Kate,
And that's
for sure.
what we need to do.
Mhm.
So we will, like I said before, right now you're just approving the architect contract. I believe the timeline, and Major, we talked about this earlier. Are we still thinking a July 2nd approval of the the site work?
Yeah, that's, Dwayne, that's what we've been, that's what Dwayne and I are working on right now. Dwayne and his team are working on finalizing drawings. My team in the background preparing the bid documents. We're going through pre-qualification of trade partners. So we'd be going out to bid mid-June.
Yeah, I think June 13th was the site package, that we would have that ready to issue.
So we would come back to the board on July 2nd to get approval for, and do a public hearing for the 500,000 to 900,000, hopefully not 900,000, but to get approval and have to contract with Murray for that work. We would do that on, go ahead.
Sorry, I don't want to correct you, but just to be clear, what we're intending to do, if we need to adjust this, I think we can. But in order to do the site work, in order to fix the soil, we have to do some of the original site work, right? So we've got to bring our bulldozers in and work on the grade. There's sanitary, water, that's under the existing building pad. We can't have those, so we have to move those. There's some mechanical condensers that have to be removed. What we're proposing is to say, if this is a hypothetical number, $15 million project, we need to do a section of that. So you're not paying for it twice, it's just you're paying for part of it early. We're probably looking around the $3 million range because that gets us, we come in and we do all of our site work, we get you new MRI pads so we can keep the MRI truck fully operational. Nothing changes for providers or patients. But that allows us to come in and get our foundation ready so that when we're through the design, we can start pouring foundations. But that gets all of the site work, so it's a bigger number, but it's something you have to do anyways to prep for this rural health.
But that's all included in the numbers that I've provided
Yep.
today. So,
Yep.
so we would get approval for that on, we're thinking July 2nd. And that would be part of our contract with Murray. And then later on, probably in end of August,
Mid-August.
mid-August is when we would come back to the board for full approval for this whole project and all the costs associated.
But in essence,
with
you're
it.
really doing that in July when you're doing the $3 million
Yeah.
project. I mean, that's when I look at it, that's the way I look
Yeah,
at
I
it.
mean,
I think it's part of the general master facility plan, though, that needs to
you
be
won't
done.
have the, we won't have the guaranteed maximum, we won't have that GMP, the guaranteed maximum price on July 2nd.
But you're still committing to it in July.
You are.
You better.
Yeah.
I mean, that's the rubber.
At least option one,
Yeah.
at minimum.
Yeah.
But, right.
So, I guess that's what I'm looking for today is just approval of the architect contract to continue to do the, well, to design the second floor of this project.
And the dollar amount
Option four.
is,
450,000, and that's in addition, so you did approve
yeah.
840 to 940,000 at the February, I think February 6th board meeting, so this would be an additional 450,000 in design fees.
I would move approval of the additional form design fees.
Second.
Well, first and a second to approve 450 additional fees. All in favor?
Aye.
Opposed? Motion carries. All right. Next, we'll go to Christie for the approval of the monthly financial statements.
Okay, so for April financial reports, it's the first 10 months of our fiscal year. So in April, we had almost 5,000 outpatient visits, over 400 emergency room visits, 148 surgical procedures, 3,659 visits to our physicians' clinics, our rollout clinics, behavioral health. Had quite a big jump there from March of last year. We had 1,716. Average daily census was at 6.72 patients. We had 7 births, 5.8 million in net operating revenue. Net operating expenses were 4.7. So there is 1.1 million in operating gain. Non-operating was 73,000, so almost a 1.2 million net income from all sources. There is an additional, as you recall, our Medicaid direct program is just ramping up. So we do know what and we should have that money today if we didn't get it yesterday, for the second payment of that Medicaid direct payment.
And that comes every quarter.
It is to come every quarter, but they're still trying to do a catch-up. So between now and the end of the year, we'll accrue at least, as we know what that amount is, to get us accrued for the first 4 quarters of this year, and then next year, hopefully we'll be seeing it timely. But we will accrue that every month just to keep us consistent so we don't see these big jumps. We just needed to get some sort of a history and a calculation as to how that was going to be.
Maybe you said, what's the approval that you're taking every month?
It's going to be a little over $300,000 a month. So for year-to-date, our outpatient visits are at 48,340, which is a 0.6% increase from last year. The emergency room visits are just slightly lower, 4711 versus 4750, which is a 0.8% decrease. Surgical procedures are up 11%, which is great. Physician clinic visits are down slightly by 1.3%. Behavioral health visits are down 0.8%. Our average daily census is down 16.5%. We haven't quite near as many births. We're down 20.5% in number of births. I know we are busy the next few months, so not sure we'll see that rebound before the end of this fiscal year, but we are seeing an increase. So from comparing for the first 10 months of the year, our revenues are up 9.9%. Expenses are up 4.5%. Our non-operating income is down 1.1%. A little of that has to do with remaining COVID funding, federal funding that we had come in yet last year. So we are at 4.3 million in net operating from all sources compared to 1.9 million last year.
But you attribute the rise in operating revenue, like 10% revenue increase.
Yeah, some of that is services, and a majority of that is we have the reimbursement for the Medicaid Direct program.
And how many months would that be in this number?
6 months.
So you've got 6 months of 300, okay, there we go.
Well, actually, we'll.
Yep, that makes sense.
Yep.
I mean, thank you.
So any questions on the financial report? There, do we have it? So then this is, again, we're comparing the last 4 years. So as you can see, our visits in the outpatient clinic has continued to rise each year. Emergency room visits, again, have dipped in 2021, but has been consistently around 4,800 for 10 months. Surgical procedures have rebounded to our pre-COVID time. Physician clinic visits, again, have increased there after everybody came back in 2022, after the pandemic started to ease up. And now we're back to where we were pre-pandemic, a little bit higher than pre-pandemic. Again, behavioral health is getting back to where we were pre-pandemic. As you can see there, our average daily census has continued to decline over these 4 years. Births, we saw a jump there in 2023, but we are consistent in 2024 and 2022 and are pretty consistent. And again, you can see our net income from all sources has gone from 4.5 to 3.1 to 1.9 to 4.3. A lot of that earlier years in 21 and 22 was our COVID federal funding that we received. Financials still look strong, our cash is strong, investments are strong. Accounts receivable still continues to look extremely high, and that's because we still cannot post payments electronically. We are doing it manually, and so we're limited to the manpower that we have. We luckily have Carter's helping us, and we have a couple other PRN students that now that they're out of school, college or high school, they're coming in and helping us kind of make that up to alleviate some overtime and some.
How long do you think that will continue? Do you think you can get that under soon?
Well, I would hope once change comes fully back up and functional, that they will recapture what we haven't been able to do it electronically, and it will be significantly lower. But we're seeing some resistance from payers of wanting to even submit information to change after they pay the claims. So they're a little hesitant that they could be exposed to some breaches, and so, you know, it's hard to say. It's going to take us months to catch up from this. We're still getting the cash in the door, and it really is just going to be a burden on the patients because they're,
But our cash flow's working now.
yeah,
It's okay.
yeah.
If a patient calls in and asks if they have a bill outstanding, can you say that with certainty at this point?
Yes, because we can look at what their insurance is
Okay.
doing, and we have access to the clearinghouse we're using now. We can look there at the claims and the payments, the remittances, and electronically see it. We just haven't got it posted to the patient account, so.
Okay, so even if
We
they
can
haven't gotten
help
the
them.
bill, if they would call in, they could find out if they had something that was of the hospital.
Yep.
Other than.
And that's then pushing those billings back to the consumer too, correct? I mean, they're not getting them on, so that's going to be some pushback from the public, you know, that says, hey,
Yeah.
I've got a bill now for 9 months, because
Why did it take you 9
that's
months?
good to know. I think that's good to have out there so that people are really not like frustrated with the hospital. It's out of our control right now.
Right.
Right? Okay.
Any more financials, Christie, or is that's what we got? Okay, can you get approval of the financials?
So moved.
First,
Second.
and second, all in favor?
Aye.
Opposed? Motion carries. And now we'll look at the approval of payroll and claims for April. Is there anything to go over there, any questions?
Anything out of the ordinary?
Go ahead and ask for approval on those.
I'll make a motion to enroll claims.
First,
Second.
and a second, all in favor?
Aye.
Opposed? Motion carries. Anything else to bring before this meeting?
Oh, I did just wonder if the board would want to consider noon meetings instead of early morning meetings. I don't know if that's a possibility or.
I would just
don't
need to
know what
know
the thoughts are.
ahead because we don't always last an hour, and so my afternoon appointments would certainly be impacted by
Okay.
that.
Okay.
And same with morning appointments, but
Yeah, yeah.
we just need to know ahead. It's just really hard when we reschedule meetings. It's like I would
Yeah.
schedule, you know.
Yeah, we've done that
clients.
quite a bit here
Yeah, we've been
lately.
doing that a lot.
Yeah. Well, I mean, the question would be that we would move to new meetings all the time
Right.
moving forward. So just, I don't know.
I'd be neutral.
I like new meetings better,
I
but
don't have a life, it doesn't matter.
It'd be nice to know ahead of time, I mean, to get this on as a regular thing, but I can make it work.
Yeah, I mean, if we're gonna start in fall, if we're gonna start in summer, but, you know, I just need to know. That's,
Yeah, okay.
I just can't know 2 weeks ahead.
okay.
I'd be in favor of it.
I know you would.
The mornings are just tough for us. And today was even worse. Nobody slept at all. That's why I'm late, so just so you know.
Well, our next board meeting will be July 2nd.
That'll be better. Yeah.
So nothing in June.
Okay.
Okay.
If you want to do June, we can do June. It's up to you guys. But July 2nd.
Okay. I'm actually not gonna be here for July 2nd. I'm gonna be on vacation. So you guys can have whatever you want.
All right.
I want to know what you do. It is.
Need a motion?
I'll move to adjourn.
Second.
All in favor?
I-
Aye.
Opposed? Motion carries.